So most of the insulins that we're going to talk about are available in what's called U100, or a concentration that's 100 units per milliliter. Okay? Regular insulin also is available in a highly concentrated form called U500, which means 500 units per milliliter. Okay? The U500 formulation for regular insulin is not used widely. It's mostly used for individuals with really extreme insulin resistance, extreme needs for insulin control. Okay? So it's really for severe conditions. Yes? When is regular insulin taken in regards to meals? So it's not going to be taken along with meals. It's going to be taken as part of a insulin regime. So it's going to be taken to cover half the day. So usually there's a insulin regimen of either, so there's taking it short acting to cover meals, and then taking a longer acting for general baseline coverage. Okay. Yes, ma'am. For diabetic emergencies? Maybe. I don't know. I've never treated anybody with a diabetic emergency, so I don't know. But it's used with great caution because it can bring about a dramatic drop in blood glucose. So it's possible if they've got an extremely high blood glucose level. Yes, sir. Mm-hmm. No, you can generally, no, you can treat insulin resistance. It may be difficult to treat, but I mean, the combination of the insulin with the oral anti-diabetic medications, you'll be able to do it. Yes, ma'am. So I think that the pumps depend, I think it depends on whether it's an implanted pump or it's an external pump, and I don't really know what the dosing regimens for the timings are for those pumps. Yes, ma'am. A high A1C is reflecting hyperglycemia. Insulin resistance is the cause of the diabetes. So it doesn't necessarily go hand in hand. Someone who's very insulin resistant but controls their blood glucose well will have a normal, or will have a good A1C. Yeah. Okay. So NPH, this is an intermediate duration insulin. This drug is going to be injected 2 or 3 times a day to provide glycemic control in between meals or during the night. NPH insulin is the only one suitable for mixing with short-acting insulins. Okay? So often the NPH is in addition to the short-acting insulins that are taken in accordance with meals. Allergic reactions are possible. Okay? NPH insulins are cloudy suspensions that must be agitated or mixed before administration. And NPH insulins are administered by sub-Q injections only. Okay. Long-duration insulins, the glargine, this is, again, a modified human insulin. It has a very prolonged action, up to 24 hours. It's a once-daily sub-Q dosing to treat adults and children with type 1 diabetes and adults with type 2 diabetes. Okay? And again, this is a clear solution because it's not NPH. Another long-duration insulin is insulin detramer. This has a slower onset, dose-dependent duration of action. So at lower doses, it has less than a 24-hour. At higher doses, it gets closer to a 24-hour. It's used to provide basal glycemic control, clear colorless solution. The dosing here is once or twice daily by sub-Q. We do not mix it with other insulins, and it must not be given IV. Okay. So as I mentioned earlier, with the exception of NPH, all the other insulins made in the United States are formulated to be clear, colorless solutions. And NPH is the only one that is cloudy. Insulins should always be inspected before using it and discard it if it looks abnormal. Yes, ma'am? So those are clinical decisions that are based on the progression of the disease, their responsiveness to glycemic control through things like diet and exercise. It really depends on how they are, what is their particular expression of the disease. Yeah. So as I mentioned, concentrations, 100 units per milliliter or U100, 500 units per milliliter, U500. U500 used really in only special cases. We do mix insulins. The most common mixing is NPH with shorter acting insulins. And when that's done, the shorter acting insulin is always pulled out first, okay, and added to the NPH. Okay, never the reverse. Administration of insulin, most commonly through sub-Q injection, the syringe and needle method, or we have pen injectors or jet injectors. Okay. Pen injectors and jet injectors are particularly good for self-administration. We also have subcutaneous infusions. We've got portable insulin pumps that are external, implantable insulin pumps that are obviously internal. Okay. Intravenous infusions for special cases or emergency conditions. And then we've got inhalation forms of insulin that are not commonly used and I don't even think are widely available. Yes, ma'am? Yes, yes. Insulin should be kept refrigerated. It can be kept at room certain insulins can be kept at room temperature, but yes, storage is very important, right? So unopened vials should always be stored under refrigeration until they're needed. Insulin should not be frozen, so you never freeze insulin. And the insulin can be used until the expiration date if it's kept refrigerated. Okay, if it's spends any time outside of refrigeration, that expiration date may not be valid. Okay, so after opening, insulin should be kept, can be kept up to 1 month without significant loss of activity, and insulin should be kept out of direct sunlight or extreme heat. Okay, it's a protein. It's going to denature if it's exposed to sunlight or extreme heat. Mixtures of insulins in vials. So if you've mixed your short-acting with the MPH, they are stable for about 1 month at room temperature and 3 months under refrigeration. Okay. Mixtures in pre-filled syringes should be stored in refrigeration for at least a week, okay, for no more than a week. They should be stored vertically with the needle pointing up, okay, so that there's no loss. If it's pointing down, you can end up with loss. Okay. So who gets insulin? So the principal indication for insulin is diabetes mellitus. Okay? It's going to be required for all patients with type 1 diabetes and many patients with type 2. There are also type 2 diabetics who are not taking insulin that are controlled using the oral diabetic drugs, anti-diabetic drugs we're going to talk about later. Okay. So even though all type 1 diabetics need to be treated with insulin and only some type 2 need to be treated with insulin, more insulin that's sold is actually used by type 2 diabetics because there's more of them. Okay, so type 2 diabetics are the biggest consumers of insulin because there's so many of them. So insulin therapy is going to be catered to the individual needs. Okay? And dosing schedules, there's 3 basic dosing schedules. So twice daily pre-mixed insulin regimens. So the twice daily mixed NPH with short-acting insulins that are given close to meal times. Okay? We have intensive a basal bolus strategy, meaning you give either NPH or the long-acting insulin once daily or maybe twice daily, okay, to give a basal coverage. And then we also have continuous subcutaneous insulin through the pumps, okay, to maintain coverage. So it really depends on the patient's needs what the dosing regimen is. So achieving this optimal glucose control, you can see how complicated the management of diabetes really can become, down to how they store their drug. Really, there's a tremendous amount of patient education necessary. So there's careful attention to really all elements of the treatment program: the diet, exercise, and insulin replacement therapy. We have a defined glycemic target, so we have a defined blood glucose level, post-meal, pre-meal, post-bedtime. We have a defined A1C target. Okay? Lots of self-monitoring of blood glucose according to the patient's individualized management plan. Patients really need to be highly motivated to do all of this work, okay? Because it's going to take a lot of work and a lot of attention to control their diabetes. So lots of patient education, and so really the responsibility for managing their diabetes is the responsibility of the patient. Okay? So it's a very difficult disease to manage at the population level because there's so much that goes into a person's ability to manage their diabetes. Complications of insulin treatment, which is also true for complications of the oral anti-diabetic drugs, the thing that we are the most concerned about is hypoglycemia. And a hypoglycemia in an adult is a blood glucose level below 70 milligrams per deciliter. Okay. Now, hypoglycemia can happen when you misjudge your treatment dose with the timing of meals or adding in factors like exercise or something like that. Okay? And so the drug, instead of maintaining a normal glucose or a reasonable glucose level, reduces your blood glucose too much. Okay? Now, if you're taking insulin with other drugs that also reduce blood glucose, your risk for hypoglycemia is increased. Okay? If you're taking insulin with other drugs that tend to increase blood glucose, and management with insulin becomes a little bit more difficult to predict. Okay? So interactions with other drugs that alter blood glucose can make management and the risk for hypoglycemia a little bit worse. Yes? So, right. So, forgetting to take your insulin is not going to result in hypoglycemia. It's going to result in hyperglycemia, right? So, because management of diabetes is mostly self-management, with children and with the elderly, it becomes complicated, right? Particularly if you have elderly that have dementia issues or anything like that. And then even in like adolescence, right? They can, but they won't do certain things, right? There's even a pattern with adolescent girls of purposely not taking their insulin as a way to prevent gaining weight when they eat. So it gets really complicated. But hypoglycemia is really a problem of more drug present than is necessary. Right. Oh, you mean if they're on like Ritalin or something like that? Yeah. Adolescents that are being treated for ADHD or ADD, Ritalin, I believe, elevates blood glucose. I'm not sure. Don't quote me on that. But yeah, any interactions with any drugs that change blood glucose is going to make insulin therapy more complicated. Yeah. And use of oral anti-diabetic drugs more complicated. So when people are experiencing hypoglycemia, there's a there's two stages to how it manifests. Okay? The first set of manifestations, signs and symptoms, is of sympathetic activation. Okay? Your sympathetic nervous system kicks into gear to try to elevate blood glucose and also to make you aware of your dropping glucose level. So you get this feeling of being jittery, you get the sweating, you get the rapid pulse, right, tachycardia. You get all of these symptoms of sympathetic activation. And then if nothing is done about it and it gets worse, the next set of manifestations are neurological, and it has to do with a lack of glucose for adequate brain activity. So you get this inappropriate speech. You get this inappropriate behavior, this confusion. Someone can look drunk, can appear intoxicated. Okay? And they can also experience seizures or loss of consciousness. Okay? Now, when people experience hypoglycemia repeatedly, when it happens somewhat often, their body gets used to it and they stop having the sympathetic activation. Okay? So they don't get that warning. They don't feel jittery. They don't get the tachycardia. And that is a situation called hypoglycemia unawareness. Okay? And so the first symptoms are the neurological stuff. Okay? So hypoglycemia really needs rapid treatment. If the patient is conscious, you want them to take in fast-acting oral sugar. Okay? Those glucose gels or the glucose tablets, they should carry around tablets like that. Juice, orange juice, sugar tablets, sugar cubes, not diet soda, right? This is not a time for diet soda. If the patient is not conscious, okay, so no swallow reflex or gag reflex, you shouldn't give anything by mouth. What they need at that point is either IV glucose or parenteral glucagon. Okay? You give them glucagon, it's going to boost their blood sugar, and it's going to help them maybe regain consciousness, and then they can consume some sugar. Okay? Now, somebody's passed out. I've seen it in movies where they're like stuffing their mouth with cookies. Don't do that. Don't do that. Okay. Other complications of insulin treatment, because this is given sub-Q, if you don't rotate the site, right, if you don't move around where you're putting it in, you can get some tissue reaction. You can get what's called lipohypertrophy, where the fat, subcutaneous fat, increases in cellularity and becomes hard. Okay? So you need to rotate the sub-Q injection sites. You can get allergic reactions. You can get hypoglycemia. Insulin promotes the movement of potassium into cells, okay, because the cell needs potassium to form glycogen. So it's not very common for hypoglycemia to result from insulin treatment, but if you're doing like, if someone has ketoacidosis, they're much more vulnerable to hypokalemia when you give them insulin. Drug interactions. Any hypoglycemic agent or hyperglycemic agent is going to make insulin treatment more complex, okay, because it's going to make it more challenging to predict the response that your body has to the insulin. Okay. Besides insulin, the other category of drugs that we use to treat diabetes are the oral anti-diabetic drugs. Okay? These drugs have ugly names, big, complicated, ugly names. They just do. Okay? Yeah, they're just alphabet soup. So we'll just walk through this together. Okay? The oral anti-diabetic drugs are mostly for type 2 diabetes. All right? Type 1 diabetics are not generally on these drugs. But type 2 diabetics will often be on these drugs even if they are also on insulin. Okay? So they're more widely used for type 2 diabetics. Many of them work by reducing liver production of glucose. Okay? So many of the drugs work by reducing the liver production of glucose or promoting the release of insulin, okay? Enhancing insulin release. Okay? Reducing liver production of glucose is going to help control the hyperglycemia, and promoting insulin release is also going to help control that hyperglycemia. So there's a couple of different categories of oral anti-diabetic drugs. We've got the biguanides, the sulfonylureas. God, I was practicing this one a million times. Thiazolidinediones, also called glitazones. Right? Right. Like, why didn't we just call it a glitazone to begin with? Right. And meglitinides. Okay? What's that? That's right, glinides. So those are the categories of these oral anti-diabetic drugs. The biguanide drugs, the most commonly used one is metformin. And metformin is a very, very widely used anti-diabetic drug. So let's talk about that one first. So it's the drug of choice for initial therapy for many patients with type 2 diabetes. And the most common side effect with metformin is GI disturbances in the form of stomach upset or diarrhea. One severe life-threatening complication or adverse effect of metformin is lactic acidosis. Okay? It's relatively rare, but when metformin is combined with certain other drugs, the risk for lactic acidosis is increased. Okay, and the one combination that you should have burned on your brain is metformin with contrast dyes. So individuals that are going in for imaging, that like MRIs with contrast, CT scans with contrast, those contrast dyes are nephrotoxic. They're very damaging to the kidneys. Okay? And when combined with metformin, can increase the risk for lactic acidosis. I believe that they are either temporarily switched to another drug, or they just discontinue metformin until the imaging is done. Yeah, yeah. So metformin can be used for pre-diabetics to prevent the onset of type 2 diabetes. It can be used in gestational diabetes to control, for glycemic control. It can be used in polycystic ovarian syndrome, or PCOS. PCOS, in addition to the problems with fertility, PCOS is also associated with some metabolic disturbances, including insulin resistance. So metformin is used to control the insulin resistance, okay, or to treat the insulin resistance. And oftentimes in patients with PCOS, the combination of fertility drugs like Clomid along with metformin can actually enhance the likelihood of normal ovulation. Okay, so women with PCOS who want to get pregnant, metformin is often combined with, or other oral anti-diabetic drugs are combined with the fertility drugs to enhance success. Okay. Other drug interactions with metformin. Metformin uses the, this is going to mean nothing to you right now, but metformin uses what we call the cationic secretory pathway for drug elimination in the kidneys. So it's a particular pathway that exists for the elimination of positively charged organic compounds. Okay? And so there are other drugs that also use this elimination pathway, okay, other cationic drugs, and they kind of compete for that elimination pathway. And so they can affect each other's levels. Okay? So some common drugs that use this pathway, amiloride, which we have talked about before, digoxin, morphine, vancomycin. Okay? So these are other drugs. It's not like you can't take them with metformin, but the metformin levels may be somewhat unpredictable when taken with these other drugs. Okay. And then what you'll find across the board in terms of drug interactions with these oral anti-diabetic drugs is, again, any drug that increases or decreases blood sugar. Okay? Particularly if you're combining these oral anti-diabetic drugs more than one together, it increases the risk for hypoglycemia. Yes? Metformin, yes, I believe so. Yes, reducing liver production of glucose. The sulfonylureas were actually the first oral anti-diabetic drug available. They promote insulin release, so they enhance insulin production. So they can really only be used for type 2 diabetics. Okay? The type 1 diabetics don't have adequate beta cell numbers to be able to respond to the sulfonylureas. The major side effects that we see with these drugs is a risk for hypoglycemia and potentially some weight gain because you get more glucose uptake by tissues. There are first-generation sulfonylureas and second-generation sulfonylureas. The second-generation drugs are used more commonly because they are more potent drugs. Okay, they're stronger medications. The sulfonylureas carry with them some risk of cardiotoxicity. They have been found to increase the risk for ischemic events in patients with coronary artery disease, which is a significant issue because coronary artery disease is very, very common among diabetics, okay, especially type 2 diabetics. And then some drug interactions beyond just the any hypoglycemic drugs or hyperglycemic drugs. The sulfonylureas, people on sulfonylureas should avoid drinking alcohol. Okay? If you combine alcohol with the sulfonylureas, it can result in a reaction that includes flushing of the skin, dizziness, nausea, tachycardia. Okay. It's like a sulfa toxicity. It enhances the toxicity effects of the sulfa drugs. There's a whole category of drugs that fall under that sulfa category, including the sulfonylureas. Yes, sir. What causes them to be cardiotoxic? What I've read is that there's just this connection that was made between ischemic events and the drugs. The only thing I read that connected it to mechanism was had to do with the drug's effect on the cardiac muscle cells' ability to handle ischemia, but it was kind of muddled. Yeah. Yes, sir. It's a good point. So you certainly will increase the workload on the beta cells. So it's not a drug that you might give someone with severely compromised beta cell function. But for patients who need sort of just a little bit of help getting under glycemic control, early diabetics or mild diabetes, it can be a good choice. Yeah. So the meglinotides, glycinides, yes. These drugs tend to, I believe they act, hold on. No. I believe that they also stimulate insulin release. They include repaglinide and taglinide. Repaglinide, if you remember, was a drug that came up when we talked about the gemfibrozole, which was the drug to the lipid-lowering drug that they interacted. Gemfibrozole can reduce blood sugar, which can increase the risk for hypoglycemia with repaglinide. Okay. But other than that, it is generally well tolerated with the primary adverse effect risk being hypoglycemia. Okay. And nab-teglamide is pharmacologically identical to repaglinide. Okay, so very similar drugs. The glitazones, they reduce glucose levels by decreasing insulin resistance, so they enhance the sensitivity of tissues to insulin. They only They're only indicated for type 2 diabetes. They're mostly used in conjunction with metformin. Rosiglitazone and pioglitazone. Okay, so the pioglitazone reduces insulin resistance and may also help reduce glucose production by the liver. It is used as an adjunct to diet and exercise to improve glycemic control in type 2 diabetic patients. It's well tolerated. It has some interesting reactions, including upper respiratory tract infections, headaches, sinusitis, and myalgia or muscle pain. Okay. The pioglitazone, the main drug interaction to be aware of is with beta blockers. And actually, beta blockers, this really applies to any drug that with a risk of hypoglycemia, because beta blockers will actually blunt that sympathetic activation, which is the early response to hypoglycemia. So you won't get the tachycardia, you won't get some of these effects that are important for alerting the patient that they are hypoglycemic. Okay? So that really applies to beta blockers taken with any of these drugs. And then, of course, any drug that increases, increases or decreases blood glucose should be taken with caution with this drug as well. Okay. Another category of anti-diabetic drugs that were not on that original list, alpha glucosidase inhibitors. These actually act at the small intestine, and they delay the absorption of carbohydrates, okay? So that your absorption of glucose is delayed. Okay? It's indicated for type 2 diabetes, right? One example of this drug is acarbose. Adverse effects, not very fun, frequent flatulence, cramps, abdominal distension. I had to look this one up. This is the most interesting word I've come across. Borborygmus? Borborygmus. This is that rumbling that you can hear from a mile away. Somebody's stomach is just gurgling and rumbling, right? So that can be embarrassing. Diarrhea and liver dysfunction. Okay, so that's a potentially uncomfortable drug to be on. Okay, miglatol, another alpha glucosidase inhibitor. For some reason, it's especially effective among Latinos and African Americans. Adverse effects, again, flatulence, abdominal discomfort, and other GI effects. But this one has not been associated with liver dysfunction, so it's more preferable to the last one.